Eighteen minutes to the top of the hour. Welcome back to the Morning Drill on Stream Television, Armstrong, and the Allegheny News Talk Sports Network. Joining us this morning, our friends from Titusville Area Hospital. Holli Wolfe joins us, and Holli, you brought in a special guest this morning.
I did. I have Dr. Rogers with me. He's our general surgeon at Titusville Area Hospital. He's been with the hospital for 5 going on 6 years. We're very fortunate to have him with us. He was actually voted this year best surgeon, best doctor in the oil region by our friends at the Titusville Herald by the poll that they did this summer. So we're very lucky to have him.
Well, good morning. Thanks for joining us this morning.
Good morning. Thank you for having me.
Yeah, let's learn a little bit about yourself. Where are you from?
I'm West Indian by birth, born in St. Kitts, St. Christopher. Moved to the United States in 1979, New York. Did my medical school there at SUNY Downstate, and finished my residency at Harrisburg Hospital in Pennsylvania.
Now, at what age did you know that this is the profession you wanted to get into?
I was 11.
11?
Yes.
Very nice. Now, did you think at 11 that you just wanted to be a doctor or
surgeon?
Surgeon?
Yep.
So you knew and that was it?
I knew and that was it, yes.
Yeah. Well, how you enjoying Pennsylvania?
I love Pennsylvania.
The seasons? You enjoy the seasons?
I was in the Midwest for a period of time, and the ability to see mountains is welcomed.
Nice change of pace, huh?
Yeah, the state is amazingly beautiful. The seasons are, I think, exaggerated. The flora, the fauna, it's just beautiful. There's really little other words to use to express the feeling I get when I'm here.
Yeah. In terms of your practice, I'm sure every day is the same, but every day is different. Is that what makes it challenging for you?
What makes it challenging for me is, I guess, the approach I use toward my patients. Some people I have heard refer to their patients as family or friends. I refer to my patients as me, what I would expect done if I were the patient. And I think if you apply that quality across the board to all patients, then you're going to have more success, and you're going to win more cases. We're not perfect. We don't win all the time. But I think if you approach each patient that way, they're going to get your best effort every time.
Are people surprised by that approach? Are they a little taken back when you first say to them, this is what I would do?
I think they are impressed that I'm a person. And not just a technician, that I care. And I think that's a big selling point in my practice, that they realize relatively quickly that I actually care and would like them to have the same feeling toward their health.
Now, Holli, I'm sure for you, that's a great thing to hear, that's the kind of approach that people are receiving when they step into the hospital. That's the kind of care they're going to have when they check in. Absolutely.
And I always say Titusville Hospital really makes my job easy because it's the people, at Titusville Area Hospital. I always hear wonderful things about Dr. Rogers and, and lots of the other physicians at the hospital. So truly, they are what makes Titusville Hospital great and makes my job easy to promote them.
Yeah. Well, so the patients that you're seeing, obviously they're coming in for different reasons.
Yes.
Is part of what you do, part of that challenge is trying to figure out the problem-solving aspect of it?
Back in training, in medical school and residency, you're taught the technical aspects of medicine. You develop an art or skill or technique in identifying how to approach each patient the way you need to get them on your side. On your side does not mean agreeing with you. It means understanding they should be part of the healthcare team also. And so I think you have to talk to, communicate, and more importantly, listen to your patient so that you can get them to see what you're trying to do for them. And what you're really trying to do for them is to arm them in the battle against their illness. And for that, you have to educate them, and you have to convince them that it's a fight they can win. They just need to try.
Well, they have to open up, right? I mean, how many times does a patient sit there and they're holding back because maybe they're afraid to say what exactly is wrong?
Well, I don't want to generalize, but I believe the majority of the times that is encountered is they're afraid of what I'm going to say, what I'm going to find. Yeah. They're afraid of the news. I only consider it bad news if you don't know what it is. I consider it weapons in your battle if you do know your enemy. The illness does not have intelligence, no brain. It has one purpose: injure, hurt you, and eventually kill you. Your job is to find out what it is and educate your patients so they can best predict, identify, and defend against it. With colon cancer, it's like termites. It sits in the wall, eats the house. You come home, open the door, and the whole thing falls down. When you develop a symptom, it's usually not a good sign. And so we have to surveil, we have to monitor, we have to screen. And the algorithms are extremely complicated and change almost monthly. But for the patient, I find the simplest approach is to educate them. Tell them what they're dealing with, win their trust, earn it, and then I think you have a better fight in the battle. And so I teach my patients. I spend quite a bit of time educating them about illness and how they should be aware of it, not fear it, and always talk to their doctor, not Dr. Google, their doctor.
It's a little scary when you do that.
Yeah.
Because then people start thinking, oh my gosh, I have this. Or maybe I have that. Yeah. The other side is we're in that fast food society, right? The TV medical society where everything's solved in 60 minutes.
Yes.
Is that tough when somebody comes in thinking, I should just be fixed right now?
I think in a way, if the television is used to get them in my office, get them in the primary care doctor's office, get them into the practitioner's offices, it's a win. Once we have them there, it's now our job to correctly educate them and arm them against the illness. So in a way, I don't think television and the media is a bad thing. I think it's an asset. It just has to be used correctly. So if they see shake and bake TV doctoring and come to me and expect it, that's great because I have them in the office. Now I can talk to them and explain how it actually occurs. If they didn't have that, they may not be in my office and I'd be called to the ER for perforated colon cancer instead of a patient with, I saw a little blood yesterday.
Prevention.
So, yes, I think it's a good thing. I don't look at those shows. It's like bringing work home.
Right.
Yeah, I can't look at those shows.
I don't know if you treated it like Jeopardy where you watch and think, I'm going to have the diagnosis before the end of the show.
Yeah, the problem is I look at it and I see the chest x-ray backward or upside down.
Oh, yeah.
I see the MRI read from a CT and I go, oh, seriously, guys, come on.
It's more stressful to watch it.
Yeah. It's entertainment for me because of the amount of training that we do and how critically we're assessed for anything we do, right or wrong, that when you have that exposure, billions of people, internet, satellites, and you put the wrong film up or you described it incorrectly, people get that impression that, oh, that's correct, and the doctor's wrong.
Yeah.
It's challenging to correct it, but I just use a little humor with my patients with that.
Sure.
I refer to it as Dr. Google.
8:51, this is the Morning Drill on Stream Television, Armstrong and the Allegheny News Talk Sports Network. You kind of mentioned this. It seems like every day something has changed in the medical field, right? A new trial or a new discovery or a new procedure or a new way of doing this. Do you sort of ignore that and wait till the documented stuff comes in and says, okay, this is working in cancer research. This is happening here. I mean, one day coffee's good for you, one day it's bad for you. It's just every day we're bombarded with all this stuff. Is it easy to kind of clear that out of the way, or do you have in your research or even your patients coming in saying, boy, I just heard this?
Well, I think my patients will tell you I refer to it sort of as flat earth theory. Sometimes you can hear something often enough that it takes on its own life and its own truth. Research is mandatory. You have to investigate and provide data based on real scientific evidence. But at the same time, a lot of those data are found by just random trial error and alleged mistakes people make that end up being miracles. Mm-hmm. And so I don't and ever dismiss an idea. Even ideas today that may seem unusual, for instance, aspirin. Aspirin was the painkiller. Then Reye syndrome occurred, and aspirin became taboo. Then they realized people have hearts and heart attacks, and now aspirin is the best thing on earth. That's a change in attitude that occurred based on data analyzing suspicion and fear. And so I think to dismiss things because they may not seem vogue or in, I think is not appropriate. At the same time, you shouldn't jump on bandwagons because they exist. You're dealing with lives. Every life you lose is a life. That is an important person that cannot be replaced. And so when you make these types of decisions, you really should make it with evidence-based medicine, not whim, fancy, or ideology. And so our practice is evidence-based practice. We follow guidelines. Guidelines aren't necessarily strict. They have certain tolerances. I tend to err on the side of caution with my patients, so I tend to err on the side of earlier screening, more aggressive screening, and a lot of information education. Other people have different practice styles, but they're all within guidelines.
Holli, give us a quick update on what's been going on with the hospital.
Well, right now is March is Colorectal Cancer Awareness Month, so we've been doing a lot of, advertising and just making people aware of that. And we're also going to be kicking off our golf tournament, so we're ramping up for that.
They're saying spring will start by June, so
I hope, because May 30th is the golf tournament. So we're hoping to have a nice sunny day that day. Hopefully not too hot, but yeah. So I've been spending a lot of time, doing that, and we're hoping it'll be successful. They haven't had one since 2014, so.
And this will be a fundraiser for the hospital?
Yes, for the foundation. All the proceeds will go to the ER campaign, which has been fairly successful. We're still pretty much on track with the ER renovations in terms of the schedule so far. Probably won't be able to start that until about September or October. At this point, we are hoping for more August, September, but it's being pushed back a little bit at this point. So still pretty close to being on schedule. So
good.
Yeah.
So if you want to help out, get that team signed up.
Absolutely.
And they're ready to hit the links. Yeah.
Titusvillehospital.org, and you can get registered right on there. Pay online. You can do your sponsorships on there. You can do everything right from there, or you can call the hospital too, and I can get you everything you need.
Okay.
So, yeah.
And again, that money will be used for all sorts of wonderful things.
Yeah, primarily the ER renovations, which will help everybody in the community, really.
Well, so. And it's the entryway that's been redone. I mean, that's an incredible improvement, and it just really changes when somebody walks in, it's like, oh, this is fresh. This is nice.
We're actually renovating the medical surgical floor right now, so the corridors up there. We're doing renovations.
Doc's like, my office is in a hallway.
No, he's good. He's on the first floor, so we haven't quite got there yet. But so if we could talk a few minutes about Colon Cancer Awareness Month.
Yeah, absolutely.
The prevention and things like that. Dr. Rogers could talk a little bit more about the prevention.
So the biggest fear that I get from my patients is not the colonoscopy, it's the prep.
Yes.
And unfortunately, you have to prep the colon. It's not clean, and we have to see. The gold standard is endoscopy, and it requires you being able to see. The cleaner the prep, the less difficult the test will be, the more accurate it will be, and the lower the complications that are possible to occur. However, there are certain situations in which you just cannot get a complete prep, and the devices are capable of cleaning most, so we can get a better visualization. That fear aside, there are many variations of preps, and I try to address the concerns of the patient within their medical illnesses and the appropriate prescriptions required. But ultimately, with our endoscopies, all patients are sedated. You are asleep, and you're not awake. You're not in twilight. You're not feeling any discomfort. The procedure is about 30 minutes. To the patient, it's a blink of an eye. And fortunately for us, we're pretty successful in finding and solving problems before they're really, really disastrous. I highly recommend that they contact their primary care physician and talk to them about it, get information about it. Come and talk to me. They're not committed. They come and talk to me. I'll inform them, and they make the decision. In my practice, the patient makes the decision. I don't tell them what to do.
What age should they start that process?
Baseline risk is age 50. The African American population risk age is 45, and patients with high risk are age 40 or 10 years before the first. It's a complicated algorithm, but I tend to try to simplify it for my patients.
So again, the best way to figure that out would be to
talk to the primary care doctor. The worst thing you can do is pretend it's not there. That's how it succeeds. Being ignored is how it wins.
What would be a warning sign that there might be a problem?
You can have blood in your stool. Unfortunately, that blood can be microscopic, and so you may not see it. And so fecal testing for blood in various forms, DNA testing. Patients can have weight loss that's unplanned or unexplained. They can have a change in the size of the bowel movements over a period of months. They can have painful bowel movements. They can have other signs of more advanced disease like jaundice or pulmonary issues. The list is long and subtle. There is no hello, wake up, bright light in the middle of the night sign of colon cancer unless it's advanced. So essentially, if you notice a change in your bowel habits or if you're at that appropriate age, come and get checked.
All right, guys, thank you so much for your time. Great conversation.
Yeah.
Holli, what'd you learn today?
I learned some more about colon cancer prevention.
Doc, how about you? Did you learn anything today?
Yes, I think the community should have communication from us, and we should have communication with them. What I learned today is that the community cares enough to have me come here and talk, and I greatly appreciate that.
Yeah, we'd love to have you back. Nice job.
We'll definitely take you up on that. Thank you.
All righty, 9 o'clock. Have a great Wednesday, everybody. We'll see you back here tomorrow for the Morning Drill on Stream Television, Armstrong, and the Allegheny News Talk Sports Network.